Dr. Bongoy. I'll be lecturing two parts. First would be cardiovascular imaging, and the second part would be interventional radiology. So I'll cover everything today. So for my second lecture, I have another schedule with you, right? So we'll just cancel it. I'll cover everything now. So I am a radiologist and my subspecialty is interventional radiology. So most of you guys seems like wondering, some radiologists can see what non-radiologists cannot see in imaging studies. So you've been through a lot of, I think in your first year and second year, so you had imaging lectures as well, right? But anyways, my task now is to but anyways, in radiology, you really have to extend your imagination. Just like here in this picture, what do you see? There's an old lady and a young lady in her lateral view, right? So there's the old lady and then there's the young lady. Hindi lagi na over.
Yung lady lang nakikita ko. May old lady, yung lady. Ang nag-suot. Saan ang old lady dyan?
Ito ba? Yan ha? Anyways, I'll be talking about basic imaging. I'll not be touching advanced imaging like MRI and CT scan and Doppler examination. So why I'm discussing basic imaging? Because most of the time when you're in the hospital, especially when you're practicing in the province, secondary, primary hospitals, you don't really get much of CT scan or MRI studies. So the first thing that you usually see and request once you are in the emergency room is you request for chest X-ray. So in chest X-ray, you can diagnose several things. It can be related to pulmonary condition or cardiac condition. Anyways, this is an advanced imaging of MRI in sagittal view and axial view. You can really depict the heart. Anatomically, you can see the heart and the great vessels in MRI as well as CT scan. In Doppler study, the advantage in color Doppler study, you can have a dynamic study flow wherein you can see shunt anomalies. Or you can also measure the ejection fraction. Okay, this is chest X-ray. Of course, all of you guys are familiar how chest X-ray is taken, right? So you stand up in a detector 6 feet away, and then with good inspiratory pace. Why do we ask you to have a good inspiratory pace? For your heart not to be large, as well as your pulmonary vasculature will not be accentuated. So going back, let's review the anatomy in chest radiograph. So it seems like it's really different from the normal anatomy in the life or cadaver. So in chest radiograph, this is your left ventricle, and then left atrial appendage, and you have the main pulmonary artery segment and then the aortic arch. And if you're going to trace down the aortic arch, you have the descending aorta. And here is your superior vena cava, and this is your the hilum. You have your pulmonary vessels, right? Right, the pulmonary vessels. Okay, that's good. So the right cardiac border is presented by your right atrium, and inferior to that, that's where your superior vena comes in. So your right ventricle, you don't usually cannot identify in PE view. So if you like to assess the right ventricle, it's best assessed in lateral view. So this is your right ventricle. Your right ventricle is positioned anteriorly. So on the posterior side of your heart, it is represented on the superior border is your left atrium, right? And then on the posterior side, that's your left ventricle. So at the hilum, that's where your bronchus as well as your pulmonary artery. Here, if you're going to trace your right ventricle, up there, that's your ascending aorta. And this is your transverse aorta. So what are the common measurements that we usually utilize in chest X-ray? We do have the cardio CT ratio, cardiothoracic ratio. How do you measure that? So you measure your cardiothoracic ratio by making an imaginary line around the spine, and then you measure the widest diameter of the right side of your heart and left side, and then you add that and divide it with the widest diameter of your chest. So to simplify, the normal CT ratio is 0.5, but actually there's a wide range of normal CT ratio. It's depending on the position of how the chest X-ray taken. Sometimes if the chest X-ray taken in a poor inspiratory phase, then you can have some corrective factor. Some it could be 0.53, 0.54. So you really have to determine whether the chest X-ray is taken in an optimal position or chest X-ray in good inspiratory phase. So again, if you're going to read the book, statistically speaking, 0.45 is normal, and it's the range of 0.45 to 0.55. To make it simple, we use 0.50. So another cardiopulmonary measurement that we usually utilize is the vascular pedicle. So it is said if your vascular pedicle is greater than 48 millimeters or greater than 53 millimeters, then most likely your patient is having a cardiogenic edema. So you really have to take note of this and then watchful of your patient. Your patient might go to pulmonary arrest. So again, what is commonly in correlation with your cardiovascular diseases are your pulmonary findings, right? Anything that you have any problem with your heart, it can be reflected to your pulmonary findings. One is when you have a failing heart, you'll develop pulmonary congestion. So what do you look at in a normal chest X-ray? You try to examine the pulmonary vasculature, whether they're dilated or not. Normally, the pulmonary vasculatures are more prominent at the basis of the lungs because by gravity, your blood would pull down the lower lung fields, and more your pulmonary vasculature in the lower lung fields would be more prominent as compared on the pulmonary on the upper lobes. But if the chest X-ray taken in supine position and in poor inspiratory phase, sometimes you'll think that this patient do have pulmonary congestion because the blood will pull down or equalize in all the lobes, right? So mostly patients who are very sick, and then the one you see in the emergency room, they are non-ambulatory, they cannot follow instructions. So most of the time, you see chest X-rays like this. So that's why you really have to examine how the technique of the chest X-ray is taken. And most of all, it's very important for you to correlate your radiographic findings with clinical data or your PE findings. Just like this is the same patient wherein the chest X-ray taken in poor inspiratory phase. You can see the heart appears to be magnified and the pulmonary vasculatures are dilated and prominent. So you might be thinking that this patient might have a pulmonary congestion. Or sometimes you might be thinking that this patient do have pneumonia. And with the same patient in good inspiratory phase and upright position, you can see the lungs is very much clear, the heart is normal in size. So here is a case of patient having a pulmonary congestion wherein your heart is enlarged. You have a left ventricular enlargement, and then central pulmonary vasculatures are prominent and dilated as well. So you have some certain degree of haziness at the paracentral area. So you can also determine what type of pulmonary congestion and the disease entity that is related with the pattern of your pulmonary congestion. If your pattern of your pulmonary congestion is on the paracentral area with a butterfly appearance, most likely these patients do have renal problems causing their pulmonary congestion. Then again, most of them, they also do have comorbidity, just like they do have renal problems at the same time with cardiovascular disease. Now, to recognize the chamber that is affected in cardiac chamber, in right ventricular enlargement, the right ventricle enlarges in anterior superior leftward direction, causing lever rotation of the heart. So what do you see in right ventricular enlargement? Instead that the left side of your heart would be dipping down to your diaphragm, it would be uplifted as compared with the left ventricular enlargement. In left ventricular enlargement, usually the left side of your heart or left ventricle would be dipping on your hemidiaphragm. So the best way to examine whether you see whether this patient do have right ventricular enlargement is to request for lateral view. In Philippine Heart Center, we routinely request for PA lateral view, but not in this center. In other center here in Davao or even in some parts of the country, mostly they will just request for PA. Probably it's just biased that in Philippine Heart Center, most of their patients are cardiac patients. That's why they routinely request for PA and lateral view. But ideally, when you request for PA and lateral view. So here, an indirect sign of right ventricular enlargement is you have dilated main pulmonary artery segment. So as you can see here, you cannot really determine or see your right ventricle in PA view. So in lateral view, in correlation with PA view, the right ventricle would dilate, so it will take much of the retrosternal space. So the right ventricle will enlarge upward, and then it will take up 2/3 space of your retrosternal space. So if the retrosternal space is occupied by 2/3 by your right ventricle, then you can be confident that this patient, you can say that this patient will have right ventricular enlargement. for right atrial enlargement, the right atrium enlarges in rightward and posterior direction. What do you see in PA, chest X-ray? From the midline, you can see the margin or the height of your right atrium would be greater than 50% of the from the base and then from the atrium of your right great vessel. So again, if you have right atrial enlargement, mostly your right main pulmonary artery segment would be dilated as well. So in left ventricular enlargement, just like what I mentioned a while ago, the left side of your heart will be prominent and then it will be dipping, and sometimes you will see the diaphragm is pushed down. So in lateral view, the posterior inferior border of your heart and the retrocardiac space would be covered by your left ventricle. So in correlation again with your PA view, with dilated inferior posterior border of your heart, then you'll be more confident to say that this patient do have left ventricular enlargement. So for left atrial enlargement, you lose your cardiac waistline. There will be straightening of the superior upper border of your left cardiac margins, and you have a double density here and splaying of your carina. Why does your carina get splayed when you have a left atrial enlargement? Doctora? So your carina is here, right? So usually your carinal angle is less than 75 degrees. So if it is more than 75 degrees, then with a double density and straightening of your cardiac waistline, so you'll be more confident to say that this patient do have left atrial appendage. Why does your carina get splayed when you have a left atrial appendage, left atrial enlargement? What?
It's because pag lumalaki yung left atrium mo, it pushes the carina.
Yeah, because your carina sits on top of your left atrium. So, correct? When your left atrium dilates, then your carina gets splayed. So, in lateral view, the superior posterior border of your heart would bulge. So, that's left atrial enlargement. So now, you can tell what chambers are affected in a chest radiograph. So of course, in a higher center, they try to correlate it with 2D echo. 2D echo would be more sensitive and in correlation with chest X-ray finding as well. Now, in congenital heart diseases, so we try to narrow down our differential diagnosis to simplify and target the disease entity that we are trying to encounter when we see patients. So to simplify our differential diagnosis when we see patients in the emergency room, so and then this patient, the relatives would say that, oh doctor, when my child got delivered and then the patient was diagnosed, my baby got diagnosed to have a congenital heart disease. So now, when you say congenital heart disease, you have a constellation of congenital heart disease. So you try to divide the congenital CHD to a cyanotic and cyanotic type. Okay? So in a cyanotic type, you have the left to right shunt, and on the cyanotic type, CHD, you have the T lesions. For a cyanotic with increased pulmonary blood flow, when you say increased pulmonary blood flow, the central pulmonary vasculature would be are prominent. So you'll have pulmonary congestion in the chest X-ray reading. So what are these lesions? You have the BSD, ASD, PDA, endocardiac cushion defect, partial anomalous pulmonary venous return. In cyanotic type, you have the transposition of great vessels, lupus arteriosus, total anomalous pulmonary venous return, tricuspid arteria without right ventricular outflow tract obstruction. So among these, wise guess, patient would come a cyanotic, and then on the chest X-ray, the cardiothoracic ratio is increased, or you have a enlarged heart, and the pulmonary vasculature shows pulmonary congestion. So, in your wildest guess, what would be the most common? VSD, right? So around you'll be correct guessing wisely for VSD. In T lesion, a baby would come in and violate shoes. Alam niyo yung they call blue baby, right? When the baby cries, they become violet or dark. So among the T lesions, what's the most common? It's not here. Transposition of tetralogy of Fallot. So again, in a cyanotic, we enlarge the pulmonary artery segment, but the pulmonary vasculatures are a bit normal. So you don't see any pulmonary congestion. So you have the aortic stenosis, coarctation of aorta, and so on. With the left ventricular inflow obstruction, you have the TATVR, progestratum, etc. And for cyanotic type, you decrease pulmonary blood flow, or you don't see pulmonary congestion. So you have also the right to left shunt. So the most common is the tetralogy of Fallot. So with increased heart, you have these conditions. Again, it's very hard to memorize this table, but at least when you see a patient in the emergency room, so you'll just narrow down, oh, what would be my wildest guess? So a cyanotic and with pulmonary congestion, so most likely this patient will have left to right shunt anomaly, so we'll be thinking of ventricular septal defect. And for patients who are violations and blue baby appearing, so tetralogy of Fallot. Okay? So another way to diagnose radiographically CHD is by pattern recognition. If you know the hemodynamics and the pathology of the CHD, then most likely you can imagine what would be the cardiac chamber that would be most likely affected, and you can predict in the chest radiograph most likely whether it is left ventricle or the atrium would enlarge first. So in ASD, again, what's the most common CHD for adult? ASD, right? Why? Most of them are asymptomatic. They become asymptomatic at early adult life. So that also depends the degree of what's the size of the ASD. So what happened? You have a volume overload going to your right atrium from your pulmonary circulation, instead of all the blood going to the left ventricle, because you have an opening of atrial septal defect, so the blood would be returning back to your right atrium, so you have a volume overload. Later on, when you develop volume overload, what happened? you develop pulmonary hypertension, right? So once you develop pulmonary hypertension, instead that the systemic side would have a high pressure, you develop also a high pressure in your pulmonary circulation. So when you have a high pressure in pulmonary circulation, then your right ventricle will be affected too. So once you have a severe pulmonary hypertension, so there will be a resistance of flow from your right side of your right atrium ventricle, and instead going to your pulmonary circulation, then your blood flow would return back to the left side of the heart. So what do you call that? Eisenmenger syndrome. So at first, with ASD, what you see, you have a right atrial enlargement, and then you develop right ventricular enlargement, and this patient develop pulmonary hypertension. And when you have a Eisenmenger syndrome or disease already, when you have increased pulmonary, when you have a pulmonary hypertension, then your left atrium will dilate as well. And it would cascade, it will have a domino effect. So here, at early age, you don't see much in ASD. So as the patient gets older, this patient develops pulmonary hypertension. You can see there's pruning of the pulmonary artery. And this patient do have a right atrial enlargement, diba? The right atrium height increases. And your main pulmonary artery segment is dilated and prominent. So that's an indirect sign that you have pulmonary congestion and right ventricular enlargement as well. So again, just like what I said, this is the most common. Adult CHD is more common in female. Usually, the symptoms would appear in early adulthood. So in BSD, the same principle. You have a defect at the ventricular septum, so you have a volume overload in the right ventricle. So what happens? What do you see? So you have dilated left atrium. Your PA would also be pulmonary artery would be dilated as well, and you develop left ventricular enlargement and right ventricular hypertrophy as well. So here, your main pulmonary artery segment is prominent, and your central pulmonary vasculature is prominent and dilated. So this is the most common CHD, and easily detected in early adulthood because in childhood because they are symptomatic. In PDA, you have persistent ductus arteriosus. Clinically, what do you see in PDA? When you examine, when you do auscultation, what's a typical sound that you hear? Okay, machine-like murmur, right? So what happened? Again, your blood flow would be shifted to your pulmonary artery. So the most common thing that you're going to see in PDA, you have a dilated pulmonary artery. So and also you have a dilated left atrium. Your pulmonary artery would be prominent or dilated. And mostly your central pulmonary vasculatures would be prominent. You'll see a certain degree of pulmonary congestion. Nowadays, you don't diagnose much PDA by using chest radiograph. Mostly they do 2D echo. Okay, so what's the problem? You have persistent left 6 aortic arch. In tetralogy of Fallot, so you have a 4-component defect in the heart. You have right ventricular hypertrophy, and you have pulmonary stenosis and VSD and overriding pulmonary artery, right? So mostly this patient will not survive. You will have severe pulmonary stenosis. So the mortality of this patient depends much on the survival of this patient depends much on the pulmonary stenosis. If the pulmonary stenosis is very severe, sometimes the invasive cardiac pediatric, they would open up an ASD to make a compensatory shunt. So, not only that you should know the hemodynamics in each CHD condition, so you can also diagnose CHD by pattern recognition. What is the pattern recognition? So in tetralogy Fallot, they always say there's this, what's the appearance of the heart? Boot shape, right? Square and sabu. So now, a patient comes into the emergency room. So what are the clinical findings that you would expect for tetralogy Fallot? Cyanotic or acyanotic? Cyanotic. And then you have an X-ray, and then you have a boot-shaped heart. So most likely, wild guess, you have a tetralogy Fallot. So you have subtypes of tetralogy Fallot. You have pink tetralogy, wherein you have ependybular hypertrophy PSD. In pentalogy, you have tetralogy plus ASD, and in trilogy of Fallot, you have pulmonary stenosis, RV hypertrophy, and patent foramen ovale. So in transposition of great vessel. So what happened in transposition of great vessel? So instead that your aorta would be originating from your left ventricle and your pulmonary artery from your right ventricle, they interchange. Okay? So for this patient to survive, do you think this patient will survive? So they should have compensatory shunt. They must have ASD and VSD. Most of these patients do have ASD and VSD as well for them to survive. So, in pattern recognition, you have an egg on its side, heart appearance. Why? Because the pulmonary trunk is absent. So, you don't have that, right? So in Einstein anomaly, what is in Einstein anomaly? Is neutralization of your right ventricle. You have a very enlarged right atrium that invades your right ventricle. Of course, this patient do have ASD as well. So in chest radiograph, they do have funnel-like shaped heart or box-like appearance heart. In hypoplastic heart syndrome, so this patient usually they don't survive. At birth, once these patients are very toxic, and they usually die within first few weeks. So you have a very small heart, and of course, most of them they also do have hyaline membrane disease. In coarctation of aorta, so you have a stenosis of your aorta, mostly after the origin of your left subclavian artery. So in coarctation of aorta, so what's the most common clinical findings in coarctation of aorta? Yes. And on the upper, you have high blood pressure. So, if you think you have a coarctation of aorta, what would be the best imaging study that you would request? Dora? If you suspect that this patient will have a coarctation for aorta, so what would be the next imaging study? MRI, yeah. Well, it's a bit expensive, right? So CT angio will also be good. 2D echo will also be good, but it's more accurate to diagnose coarctation in MRI or CTA. So in ordinary radiograph, it's very hard to diagnose coarctation for aorta. In total anomalous of pulmonary venous return, so what happened to pulmonary TATDR? Doctora? So normally, your pulmonary circulation would go to the left side of your heart, right? In total anomalous pulmonary venous return, you have an abnormal communication. Your blood from pulmonary circulation would go back to the right side of the heart. So most likely, that anomaly would go to the coronary sinus of the right atrium. So in pattern recognition, you do see a figure of 8 or Snowman's sign. So if you have total anomalous pulmonary venous return, you also do have partial anomalous pulmonary venous return. So what's the pathology in partial anomalous pulmonary venous return? That's good. You have my lecture already? Doctora. So in partial anomalous pulmonary venous return, instead all the pulmonary circulation goes back to the right side of the heart. It's only a portion, it's mostly the right lower lobe. You have an anomalous pulmonary vein that goes to your right side of your heart. So it drains to the right atrium. So what happens? So what you see, there's prominent or dilated anomalous pulmonary vein that drains to your right side, and it forms just like a sickle or a scimitar sign. So if you suspect this patient do have partial anomalous pulmonary venous return, because this patient usually do have persistent or recurrent pneumonia. So to diagnose this, you request for CT angiogram for you to document for that partial anomalous pulmonary venous, partial anomalous vein. I used to do transarterial angiogram that was 20 years back when the CT angio is not yet available. So you try to cannulate, you do an aortogram and then look for this anomalous vein. In acquired cardiovascular diseases, so most of the acquired cardiovascular diseases are related with your hypertension, atherosclerosis with high cholesterol. So in intrinsic aortic valve disease, these are the common conditions that causes the intrinsic aortic valve disease. So what happens if you have intrinsic aortic valve disease? So mostly they have stenotic valves. So if you have a stenotic or non-responsive aortic valve, what would be, by hemodynamics, what would be the chamber that would be most likely affected? You have output resistance from your left ventricle, right? So your left ventricle will be working harder as compared to normal. So this patient will develop left ventricular hypertrophy at first. And then later on, once your left ventricle fails, so you develop left ventricular enlargement. And later on, there will be non-contraction of your aortic valve. No, of your mitral valve, and you develop later on left atrial enlargement. Previously, in primary disease, what's common is the syphilitic aortitis and rheumatoid arthritis, where the antibiotic was not yet available. But nowadays, it's we don't see much of these cases here in the Philippines, probably in some other third world countries. So in mitral valve stenosis, around in the 70s or 60s, this is common. So probably you have relatives that do have rheumatic heart disease, you heard of them. So what happened? They get infected and then they develop mitral valve stenosis. So if you have mitral valve stenosis, so what would be the cardiac chamber that would be most likely affected? Left atrium, right? So you will see left atrial enlargement in chest X-ray here. So these are less common conditions that you usually see. If you see a bulge in the heart, so what would be your differential diagnosis? Doctora, if you see a bulge or something unusual in a chest X-ray like that, and then this patient had a history of heart attack, so what would you be thinking? What would be your differential diagnosis? Yeah, aneurysm, right? Why? Because when you have an infarct, a part of your heart, there will be weakening of that wall, so it will bulge. But to be honest, I haven't seen one yet. It's very hard to diagnose. And then if I see one bulging like that somewhere in the heart, I would not jump to the conclusion that this patient do have aneurysm, cardiac aneurysm. You'll first think of something like, can this be a new growth, a pericardial cyst? Then, if you have a high index of suspicion, then you request for 2D echo or MRA or CT, so you can see there the staining of the wall of the left ventricle. So it's confirmed that you have a left ventricular aneurysm. So here, Doctora, what do you see? Akin yan. That's your bone. Yeah, that's nice. Yeah. That's good. What do you see? Anyone? Can anyone describe what you see in a chest radiogram? Doctora? Dr. Bahul? Don't worry. Walang mali. Sorry? I can't hear you. Can you tell them? Bulging. Are you sure? If you are presented with that chest X-ray, you'll say you have bulging. Yeah, because you saw it already in your notes, right? Yeah, you're correct. But let's say you encounter in the emergency room, and then of course this patient do have coughing and difficulty breathing, and then you requested for chest X-ray, and you see that chest X-ray. So what would you say? So what would be the first thing that would come into your mind? There's a homogeneous opacity in the left lower lung field, right? So what are the possible things that can cause homogeneous opacification or loss of your cardiac shadow and that heavy diaphragm? Let's not talk about heart. What's the most common? Probably you heard already a lecture from Dr. Tupas. You have the
Pleural effusion.
yeah. That's the first thing that you're going to think of, right? Pleural effusion. Why? It's most common. Another thing, what other differentials that you're going to think of? Sorry. Atelectasis, yeah, but most likely what happened in atelectasis, you have a collapsed lung, right? So your intestinal structure will be shifted to the left side because you have a collapsed lung. In pleural effusion, if your pleural effusion is not that much, so your intestinal structure is still in the middle. How about mass? Right? I get a lot of referrals when the pulmonologists would talk blindly this thing because they think it's a pleural effusion. It's okay. If you're right, this is a left ventricular aneurysm. My God, it would be devastating when you do a blind talk.
Oo.
And most of the time when we do it, of course, when we do an intervention, we do it under imaging guidelines, we do ultrasound guidelines. So we can confirm whether it's fluid, solid. So in your notes, so you know already this is a left ventricular aneurysm, right? Because you already have the note. But in reality, when you see this, so you think first of pleural effusion, could leave a mass, or probably this patient will have consolidation. And then you requested for lateral view. So what happened? Is that what you see in lateral view for pleural effusion? No, right? You lose your hemidiaphragm. Most likely, this is at the posterior side would be opacified as well, white then. Then now, what you'll be thinking of? Narrow down your differential diagnosis. It's not pleural effusion, so what can it be? Mass. If I'm going to have a wild guess, I'll be thinking of a mass first rather than left ventricular aneurysm. So now, to confirm your diagnosis, what would be your next request? CT. That's the cheapest. Not cheapest. To the doctor. Pero if you're thinking of a mass lesion, then go ahead for CT. So at least you'll see the entire picture of your chest. So here, they had MRI, so you saw a left ventricular aneurysm. So in aortic aneurysm, this is also common aortic aneurysm, right, in elderly because of hypertension and high cholesterol, and if they do have connective tissue diseases like Marfan syndrome, so they develop aortic aneurysm. So what do you see in aortic aneurysm? If you see a chest radiograph like this, you have a prominent and it seems like dilated aorta. Would you right away jump to the conclusion that this patient do have aortic aneurysm? What happens when you get old? Dora? Sorry? Thinning. No, I mean, you don't see it in chest radiograph. In ordinary chest radiograph, you just see two dimensions. In CT and MRI, you see 3 dimensions. So what you're dealing with a chest radiograph is only gray, black, and white, right? So actually, you don't have the depth perspective in a chest radiograph. That's why you request for lateral view so you can correlate it. But anyways, if you have a prominent aorta, be cautious because when we get old, our aorta will become atherosclerotic. It turns and becomes tortuous. It would appear like in PA view, you have an aortic aneurysm. So to confirm your diagnosis, the most simplest and cheapest request lateral chest X-ray. So you can see your descending aorta, your aorta in better perspective, right? So if you see you have a dilated aorta, then confirm. So here, a flashing appearance is you already saw true cardiac cardiomegaly, right? When you have left ventricular enlargement, left atrial enlargement, you have this pattern in your heart. But in pericardial effusion, you do have a flash-shaped appearance. So if you see this, to confirm your diagnosis, you request for 2D echo or ultrasound to see whether you have pericardial effusion. So in pulmonary edema, what do you see in pulmonary edema? You have 3 stages in pulmonary edema. So what are the 3 stages in pulmonary edema? You have cephalization. Just like I mentioned earlier, your pulmonary vasculature are more prominent at the basis, right? Because of the gravity, the law of gravity, your vessels will be dilated more on the lower lung field. But when you develop congestive heart failure, so you need more oxygenation for your body. So you need to recruit more oxygenation. So your pulmonary vasculature in your upper lobe would dilate. So you'll see your pulmonary vasculature in the upper lobe will become prominent. So what you call cephalization. So once the pulmonary vasculature in the upper lobe as well as the lower lobe become equal, so you call it equalization, right? Next is once your fluids extravasates from your interstitium and goes to your alveoli, you have the pulmonary edema already. Ito, may pulmonary edema na ba ito, Doctor? Some certain degree. You will see already some Apache densities there. And your pulmonary vasculatures are prominent, and you have prominent upper vessels upper lobe. So in chronic PH, you already discussed that. You have pruning of your pulmonary artery, and you have anemic lung. And then your main pulmonary artery segment is prominent. And what do you see? What cardiac chamber would be dilated in pulmonary hypertension? Is it the left side of your heart or the right side of your heart? Right, right? So you develop right ventricular enlargement and RA as well. So, Western mark sign. So yan, favorite nila yan sa board. Oh. I had a patient. Patient drove from Boston to New York. And then suddenly, that's 5 hours drive. And then suddenly this patient arriving at New York, young guy, around 30, right? And developed a severe chest pain. And then chest x-ray. So probably you studied the whole night without studying. Because You have to finish this chapter. I don't want to pee. And then suddenly, in the early morning, you develop severe chest pain. So what would be your differential? And then chest X-ray, you have a focal hypovascular area. Betul? PE, think of PE, right? Oh, baka na heart attack. Pero okay naman. The heart is good. You don't have pulmonary congestion. So what would you request? To confirm that you have PE, pulmonary embolism.
Yan.
Sorry? Angiogram. Those were the days I do angiogram. But now with a newer technology, less invasive, Doppler, yeah, you can do Doppler examination, and then what do you see in Doppler examination? You do have DVTs, right? Deep vein thrombosis. Then you'll be thinking of PE, pulmonary embolism. This patient who have that. Is it automatically when you have DVT, you have pulmonary embolism? No, you cannot diagnose pulmonary embolism because you do diagnose by ultrasound this patient who have DVT. So you request for 2D dimer, laboratory-wise, and to confirm your diagnosis, you request for CTA, CT angio. Okay? So you see the thrombus. So then this patient will be referred to us. We'll do thrombolysis, put in a catheter to pulmonary artery, and if this patient do have DVTs, we will put IVC filters. Okay, this is again, this surgical medical emergency. So what are the most common symptoms for patients who have aortic dissection? Just chest pain, right? Severe chest pain. Patients are hypertensive. So do you see anything in chest radiogram? Not much. So what do you request? Of course, you requested for regular X-ray, but you don't see anything much. You can see left ventricular enlargement, the aorta is quite good, right? Pulmonary vascular lung findings are normal, but this patient do have severe chest pain. So what would be your next move? CT scan, yeah. But if the cardiologist see this first, they'll do 2D echo first. You can also see dissection in 2D echo. But confirmatory-wise, the best imaging modality would CTA, CT scan. So you can really see the dissection in CT scan. So here, this is a ruptured aortic dissection. You can see the blood already pooling around the mediastinum. So this is dissected aorta. You can see the true lumen. This is the false lumen, and this is the plug. Sino man sikat na itik na matay? Si First Gentleman, right? Ano sa yung asawa ni Macbagal? Si First Gentleman? Good thing for him. He survived. But this is a medical emergency. So, in aortic dissection, you have several types, DeBakey type 1, 2, 3, and subtypes as well. So, in DeBakey type 1, the ascending aorta and portion of distal arch is affected. And in DeBakey type 2, it's only the ascending aorta. In DeBakey type 3, and what's type of surgical emergency? Usually they would recommend for emergency surgery DeBakey type 1 and 2 when the ascending aorta is affected. Why? Because if the dissection goes down to your coronary sinus, this patient dies. In DeBakey type 3, mostly these patients are treated medically. But nowadays, because of TBAR, before, when they do open surgery for DeBakey type 3, wherein the descending aorta is affected, and most of these patients become paralyzed because of the spinal artery of Adamkiewicz is compromised. Spinal artery of Adamkiewicz, right? So what's spinal artery of Adamkiewicz? That's the main blood vessel that supplies your spinal cord. So that's a branch coming from your descending aorta, actually technically speaking by intercostal artery. So another subtype is classification Stanford A and Stanford B. The Bakey type 1 and 2 is almost the same with Stanford A and type 3 is Stanford B. So that's how you classify your aortic dissection. So I think this ends my first part of the lecture. Let's take a 5-minute break, then I'll be discussing about interventional radiology.